Thank you for having me here today and joining us for this session. My name again is Hope Young. I'm the Advanced Care Planning Coordinator with Kokua. Kokua is a 501c3 nonprofit. We're a community benefit organization and we're statewide. And we are supported by members. Our members include health plans, hospitals, long-term care organizations, senior living communities. We have churches and temples, hospices, home health agencies, and passionate individuals that support us in the work that we do. And they see the value in advanced care planning. I'm also fortunate to work with passionate volunteers across the state. I get to work with some social workers, nurses, doctors. They volunteer their time. We call those our ambassadors, but they see the value in having these conversations and the importance of advanced care planning. Our three areas of activity are that we work with people who may be facing serious illnesses, and that would include dementia and Alzheimer's, as well as their loved ones to understand the decisions they may need to make decisions as early as possible. We want to make sure that people have good information. We also provide some professional networking and training to the people who are in the front lines, who are doing these conversations out there in the field. We dabble in legislation and try and, if you're familiar with the POLST form, that's something Kokua pushed through. We'd like to point out that we do have on our website a lot of resources. We have a page specifically designed for advanced dementia and different issues that are available and that you may want resources for. We also have resources for Alzheimer's resource. We want to make sure that you have that information readily available for you. I came across this and I love the artwork on this, and I just wanted to share this with you folks. The photographer did a bunch of pictures of people with Alzheimer's looking in the mirrors, and they were gorgeous. So if you have some time or you want to kind of take a look, I invite you to go and take a look at that. Some additional articles on advanced care planning with specific guidelines for dementia are here as well. And as Jody mentioned, she'll have the slides available for you so that you can get these links a little bit later on. We do like humor. This is a challenging subject, but we find that when we use some humor, it's not so scary. Because as you can see, communicating with dead people is easy, but communicating with live people can be really hard. So Kokua, we like to say we're leading a movement. And the movement aims to make advanced care planning and open communication about end-of-life care a cultural norm. We want to stop being afraid of having these conversations and actually embrace the idea that we should be talking about this. I'm not afraid of life. I just don't want to be there when it happens. And I'm right there with you, Woody. I totally am with you. And finally, this is one of my favorite as far as humor goes, is just so you know, I never want to live in a vegetative state dependent on some machine. If that ever happens to me, just unplug me. And we might know a few people like that right about now. So our goals for today are talking about the importance of having these conversations, the importance of advanced care planning, advanced directives and how to complete those, and also getting additional tools so that you can facilitate these conversations with your loved ones. So what is advanced care planning? Well, it's an ongoing process. It's thinking about, it's talking about, it's writing and sharing your healthcare wishes and learning who is able to honor your wishes. Who can you ask to be your champion that will advocate on your behalf? Why is it important? Well, I usually say this in-person events. Who's planning on getting dementia? It's not something that we normally think about planning to get, but no one knows when you're going to become very ill. It helps your loved ones find your voice. It eases the burdens for others to make decisions. And really, right now, in times of COVID, they're doing things differently. Care is being provided differently. Whether it's a doctor's office or the hospital, there are some things to consider, and especially consider when it's a loved one with dementia. Depending on where they're placed in the hospital, they might not be able to get visitors as often as possible. It really depends on the unit. So this is why we really encourage you to have these conversations. Without advanced care planning, without these conversations, it's oftentimes crisis-driven care. It's often reactive and unplanned. We're guessing. We're trying to figure out what to do, right? When we haven't had these conversations, then we really don't know how to proceed. And we also risk of getting medical error providing unwanted care. Maybe the individual didn't want as much intervention as we think they did. So in order to avoid having your family and your loved ones to guess what you want, we encourage you to have these conversations, right? When we plan ahead, people are less likely to die in a hospital. They're less likely to receive a feeding tube, and they're less likely to use a ventilator in the last month of life. That's an interesting point to say, right? But it also reduces hospitalization. When we have these conversations, it improves patient and family satisfaction. And let's face it, there's no impact on mortality when we talk about death. Last time I checked, mortality rate was still at 100%. None of us get out of here alive, so let's have a conversation about it. So normally I would ask for responses, but I'll go ahead and respond for you. When there is a hurricane, they're saying a hurricane's coming, what do? We go to Costco, we buy toilet paper, must have toilet paper. We buy water, we buy batteries, we stock up on foods, we make sure our prescriptions are filled. We do something, hoping that that hurricane is not going to hit, right? Sometimes it hits, sometimes it doesn't, but we're preparing for a hurricane. So why don't we do this for ourselves? Why don't we prepare for our own health challenges and health issues that could possibly come up? So we use the Conversation Project as a toolkit, and the Conversation Project is actually based out of the Institute for Healthcare Improvement. They are a public engagement campaign, and they're dedicated to ensure that everyone's wishes for end-of-life care are expressed and respected. This came about when Pulitzer Prize-winning author Ellen Goodman, her mother was diagnosed with early onset dementia. And she learned quite quickly that she hadn't asked the questions that she would have benefited knowing the answers. So she worked with the Institute for Healthcare Improvement, and they developed the Conversation Project. Their webpage has a whole bunch of tools that are available for free to download. They do have starter kits just for healthy individuals. They have starter kits for people with seriously ill children. They have starter kits for loved ones with dementia and Alzheimer's. They have starter kits on how to choose your agent, how to talk to your doctor. They've even developed some new starter kits in the time of COVID to kind of just make sure that there are additional resources available. And you'll see the purple one is the Alzheimer's starter kit. Again, these are all free to download online, and I invite you to go check them out. So when we're doing the starter kit, we want to make sure that you have the answers. Have your answers. Think about it thoroughly, right? Before we move on, I'd like to invite you to take a moment to just still your mind, clear your mind from worrying about what's for dinner. Did I remember to call somebody back? I'd like you to just take a few brief moments, maybe a cleansing breath. And what matters to me at the end of life is, consider that. What matters to me at the end of life is, who would be there? Where would you be? Are there sounds in the background? Is there music playing? Again, the question that we're pondering is, what matters to me at the end of life is. And if you'll take a look at this Wordle, the larger the word, the more times people responded with that as a idea of what matters to them at the end of life. Notice the largest one is peaceful, comfortable, with family and friends, happy, laughter. You'll notice nobody is saying suffering. Nobody is saying in pain. For the most part, we as humans hope that the end of life is a positive event for us, as best as can be. Some answers that were given to that question, what matters to me at the end of life? I want to say goodbye to everyone I love, have one last look at the ocean, listen to some 90s music, and go. Wow, that sounds really cool. I mean, you may have a different idea on what music genre to listen to, but if it were that easy, that sounds not so bad. Having my sheets untucked around my feet. I like to point this one out because my mom, and you'll hear about her from throughout this presentation, mom had, she had slight dementia. She had congestive heart failure. She had some challenging arthritis. So her tactile motor, she wasn't very good with that. And she also had Parkinson's. And she wound up in the ICU when she hadn't taken her Parkinson's medications, which allows her to swallow. And so it was kind of a snowball effect because she couldn't swallow, she couldn't take her medications, and she couldn't eat. So she got weak. She wound up in the ICU. And in the ICU, the nurses would come around and tuck her feet in. And she'd spend the next 10 minutes kicking her feet out. So I decided to write a sign for her and put it next to her bed and say, please don't tuck my sheets in. I like my feet uncovered. The nurses really appreciated knowing that. They appreciated recognizing how to keep mom comfortable. I'm sure mom appreciated not having to spend 10 minutes untucking her feet. So what matters to you might be very different than what matters to others, but it's also really important to share that with the ones you love. Now, the starter kit, there's only 9 questions. There's no right or wrong answers. I encourage you to take the time and go through these answers. The examples online on the screen right now is, as a patient, I'd like to know only the basics about my condition and my treatment. Or you could be all the way on the other side and say, I want to know everything. Tell me all the details. Or you could be somewhere in between. Again, there's only 9 questions. There's no right or wrong answer. I have a friend who her sister was an RN, and her sister was diagnosed with stage 4 cancer. As an RN, the sister already knew what she wanted. She definitely knew what she did not want. And the family was doing all kinds of fighting because they couldn't understand what was going on. So she called me up and she said, you work in this field. What can I do with this? I sent her a copy of the starter kit and I said, as a family, sit down and everyone share your answers, not just focusing on Sissy, everyone share your answers. She called me the next day and she said that was the best 2-hour conversation our family has had in the last 6 months. We all know how to support each other, but more importantly, we know what's important to Sissy. So I really call this a relationship building tool. I encourage you to do these, or at least share your answers with your tribe, with the people who are going to show up for you. These are the people that would want to know what matters to you. So it gives you an opportunity to think about who would be most important to have this conversation with. And I want you to keep in mind that the way that this works well is if you do it for yourself first before asking someone else to do it. So as we go through this, think of this as I'm doing this for myself so that I can help share what I've learned with others. So who would you want to talk to? Your spouse, siblings, cousins, children, parents? And when would be a good time? Soon is not a time to talk. Remember, soon doesn't count. So when a couple of years ago, we had Reverend Rosemary Lloyd come and do a presentation with us. She visited us all the way from Boston. And she's the spiritual consultant for the Conversation Project. And she shared a story. And her story was in the month of November, she had been doing a series on end of life at her church. And one of her parishioners came up to her and was so excited. And she shared with her Thanksgiving invitation. And on our Thanksgiving invitation, it had time and date. And at the very end, it had, there will be no pie until you tell me how you want to die. And I think that's just a genius way of approaching this. She was so excited about this, but the brave ones who showed up knew what they were in for. And they knew that it wasn't around somebody who was sick. It wasn't around anyone who had serious illness going on. It was just an opportunity to get loved ones together and talk about what matters most. So again, who needs to hear your choices on what matters most? Another toolkit another tool that's actually really helpful if you're in this world where you're trying to figure out what's important to you. I invite you to go to the gowish.org website. Online, they have cards that look like what you're seeing on the screen, and you're going to be putting that in three different categories. Ones that are very important to you, ones that are somewhat important to you, and ones that really aren't important. And again, if you look at it, this is a slice of what the cards look like. There's about 36 of them in the deck, but that gives you the opportunity to figure out what matters most to you and what you really want to share with your loved ones. On the website, you can print it out, you can share it with others, you can do it over and over again, share your outcomes with your loved ones. But it's also another tool to get your mind thinking about what's most important to you. Because remember, we're not talking about dying, we're talking about living well, all the way up until time of death. And that's really what we're encouraging you to do, is facilitate these conversations and know how to support one another throughout health crisis, throughout lifetimes. And to do that, we have to have these conversations. So when you start initiating the conversation, sometimes it can be awkward, especially if this is not a subject that you've talked about in the past. But remind loved ones that, hey, I'm not doing it to scare you. Everyone over the age of 18 should have an advance directive. And that advance directive would appoint your healthcare agent. Remember, there are no right or wrong answers. Completing the documents actually is a gift for your loved ones. And it really helps your loved ones know how to support you should you have a health crisis. For those of you who are caregivers, you may recognize that, hey, we never had this with my loved ones, and now they've gone beyond having these conversations. We still have some tools for you as well. But remember, this is just a starting point. Nothing is set in stone. You can change it at any time. But these conversations really are to help us to know how to care for each other. So we want to be sure that we establish that. Sometimes it is easier to initiate the conversation around things that the person might not want, rather than what would you want. And when you're having these conversations with regards to someone with cognitive impairments, think about what they would have wanted prior to the impairment. Think about what was important to them. And as much as possible, include them in the conversation, because they still have some opportunities. Sometimes they still are able to express themselves. And also keep in mind that the pandemic has changed the way care is being provided in the hospital settings, which is something that you may want to talk a little bit more in depth with your loved ones. Because if the unexpected happens, who would speak for you? And would they know what you would want, or possibly what you would not want? And did you know everyone over the age of 18 really should have an advance directive, which appoints a healthcare agent? Because without that advance directive, without designating that healthcare agent, precious time could be spent trying to figure out who's in charge. In the state of Hawaii, there's no next of kin law. So it's really important to recognize that just because you're married doesn't mean your spouse is going to be able to step in. Just because you have children doesn't mean your oldest is the next in line to be in charge. You have the authority and the opportunity to name who it is that you would want to speak on your behalf. And that is such a gift for your loved ones. Because without that gift, what they'll do is they'll call a meeting. And everyone who wants to be involved with your care or your loved one's care, they're asked to come into a room and agree on something. Now, if you have a big family, trying to get everyone to agree on something might be a challenge. For my family, it's usually the loudest person wins. I am often the loudest person, but I don't necessarily know what you would want unless you've told it to me. So it's important to say that to avoid the infighting, to avoid the family conflict, name your agent. If that's the least thing you do, that's already a gift. Otherwise, it could go into a guardianship case when your loved ones, when your interested parties cannot come to an agreement. It could find itself in the courts where you go for guardianship. And that could be expensive, and that could usually take about 6 months to resolve. So as a gift to your loved ones, name your agent. I also call that person your champion, your advocate, your person. Name them, because we do all kinds of planning throughout life, right? We plan all types of things: financial, legal, personal, health. Advanced care planning is just one of those things that we should include in this as just being responsible. So our advanced directive, we have the free downloadable version online on our website. We encourage you to download it. If you go to a lawyer and you're doing trust or maybe your will, they might try to include this. I strongly suggest that you thank them, but say you've already done it or you plan to do it on your own, and you will have saved yourself hundreds of dollars, because the advanced directive is really your words. And it's something that you can change as what matters to you changes. So do it yourself. So what is the advanced directive? Well, it's a legal document completed only when you're of sound mind. So I recognize that it might not be something that some of our audience's loved ones might be able to do at this time. But what it does, and I want to again remind you that you're doing this for yourself, right? We're doing this for ourselves first. It appoints your healthcare power of attorney, also called your healthcare agent. I also refer to them, like I said, your person, your champion, your advocate. That's your person that's going to speak on your behalf. And then it gives a second section, which would give the instructions for your choices at end of life. So it's a two-part document. The first part: who do you trust to make healthcare decisions for you when you cannot? This person needs to be familiar with your personal values. And this person also has to be willing to make decisions. So that's why these conversations that we were just talking about are so important, because in order to choose a good healthcare power of attorney, they need to know what's important to you. It doesn't have to be a family member. You don't automatically have to choose your spouse or your firstborn. It can be a friend, but you also want to choose an alternate, because if you're in the car with your loved one that you have chosen as your agent and you get into an accident, that agent might not be able to be an agent at that time. So you want to have a second person, an alternate that can step into that role. Again, when does this document come into play? Well, it really is if I have lost the ability to communicate my wishes regarding my healthcare, and it is unlikely that I will ever recover that ability. Or we're coming to the end of life and I have an incurable or irreversible condition that will result in my death within a relatively short time. Or if the likely risks and burdens of treatment would outweigh the expected benefits. So it's really meant for a particular point in time when this document takes effect. One of the questions on this, and this is kind of the first one that hits you, is choice to prolong or not prolong life. So you have two choices listed on there. I want to stop or hold medical treatment that would prolong my life, or I want medical treatment that would prolong my life as long as possible within the limits of generally accepted healthcare standards. Whew, that's a lot of words. What does that mean? Well, let's break this down. If you've ever been to the ICU, if you've ever visited somebody in the ICU, that is generally accepted healthcare standards. So they can keep a person alive for quite some time using medical intervention. This is a choice. It's a personal choice. What would you want? Would you want to be in a hospital setting? Would you want to just let nature take its course? And if you're saying, let's let nature take its course, you're looking at the first option. I want to stop or hold medical treatment that would prolong my life. I want to allow for a natural death. Or, hey, I want to try everything. If there's a chance that I could recover, let's do that. This is a personal decision. This is one that you get to choose for yourself, and give direction to your loved ones so they know what's important to you. Second section, and we're going to hear more from Dorothy at the end of my session, but artificial nutrition and hydration, this is something that you also get to give as a gift. Artificial nutrition and hydration, they will always try to feed by mouth. They will always try. Keep that in mind. They're not, if you say you want artificial nutrition and hydration, that's fine. It's a personal decision. I will tell you, when Mom was in the ICU, she had checked on her forms that she wanted artificial nutrition and hydration. she opted for it. Now, mom, because she hadn't had any of her medications, she was clear. She was speaking coherently. She was in charge. I just let her keep her, she was in control of her decision making. So because the nurses already had her advanced healthcare directive, the nurse came in with the tube feeding, the temporary tube feeding. And she said, okay, we're going to try this. And so with the temporary tube feeding, they go through the nose, up the nose, down the throat, and into the belly. This is how they do it as a temporary tube feeding. And this is how they get the nutrition to the belly. So they put the tube in, and immediately mom said, get it out, it hurts. The nurse took it out and said, okay, we'll try again a little bit later. The idea was to get her, get some fuel in her, get some nutrition in her, hopefully to get her a little bit stronger so she could get her medications. Second time the nurse came in the nose, down the throat, into the belly, she absolutely looked at me and said, get this out, it hurts. Okay. The third time the nurse came in, she said, I don't want that. Thankfully for me, mom was awake, she was alert, and she was able to guide her care. Had she not been awake, had she been semi-comatose, we would have tried with the artificial nutrition and hydration, but that would have been her wishes, right? So I would have been honoring her wishes. So again, the document, it's a guideline, it's a way to guide decision-making for your champion, for your advocate, but as long as you are alert and aware, you are still in control of whatever care you choose to opt for. It's important to recognize that artificial nutrition and hydration are personal decisions. In some cases, it can prolong life. When they do a permanent tube feeding, it's through the belly. When in some cases, it might not help. It is also important to say that tube feedings are not recommended for those with dementia. And I'm sorry, it looks like it cut off the website, but I'm sure we can get that for you later. People with dementia, it's not recommended. So mom's mom, grandma, she had dementia, and in her last couple of years of life, she actually had a tube feeding. And unfortunately, we saw her trying to pull that out. So they did have to like restrain her arms because she wanted to get that out. At the very end, she kept trying to pull it out. So tube feedings are really not recommended for those with dementia, but it can be a personal choice. I also want to point out that especially here in Hawaii, food is love, right? When you think of plate lunch, mixed plate, that was created because people shared food with each other. And culturally, we find feeding each other as a way of showing our aloha. So by making this decision yourself, you are taking that burden away from your loved ones on trying to figure out what you want. And if you say you want a time trial, keep in mind that means at the end of time trial, if you're not improving, they will need to take that away. And for some, that can be very traumatizing to see that food being taken away from a loved one. So this is a personal decision that you have the opportunity to tell your loved ones what you want, and so that they don't have to guess. Pain and pain relief, you want to give your loved ones as much information as possible with regards to your wishes. And pain, hey, it's a personal decision. Some people say, I want to be wide awake. I don't want any medications because medications can make me groggy. That's their choice, and this is your opportunity to honor that. Some people may say, hey, give me the meds. I'm happy with that. Again, this is your personal choice, and this is a way to honor it. Then you have a section on what is important to me. This is your opportunity to say what makes life meaningful, what would make quality of life unacceptable, and give more specifics on a trial of support. If you're trying the tube feeding for a certain amount of time, if you're trying the respirator for a certain amount of time, this is where you could put all that information in there. This is where you could say, hey, if I can't have my chocolate and watch my Korean soaps in peace comfortably, let's not do any prolonging measures. Or it's a place where you can say, hey, if I get dementia, hang on to those cholesterol pills. Don't worry about that. I don't need that. Just give me the ice cream and let me be happy. This is your place to say what matters to you. This is also your place to say when you would want them to stop treatments, if there's a time that you would want that. In order to make this document legal, it needs to be either notarized or 2 witnesses. Now keep in mind, the witnesses must be over the age of 18. It cannot be your healthcare agent, so the person that you name as your agent. It cannot be a healthcare provider or an employee of a healthcare facility where you are receiving care. 1 witness cannot have inheritance right. And you can actually get it right now during COVID, electronic notaries. So in order to make this document legal, you want to have it either notarized or witnessed. Now, once you got your copy and your document completed, what do you do with it, right? So you want to make sure your agent has a copy. You want to make sure that your health system, wherever you're getting care from, has a copy of it. You want to keep one readily available, and you want to share it with your loved ones. Even if you don't have the copy to share with them, you could say, hey, I did my advance directive, and guess who's in charge? You can tell them who you've appointed as your agent. You can actually put it on your driver's license. So if you're in a car accident, they pull out your license, there's a little designation at the very bottom saying that you have an advanced healthcare directive. And what you want to do is review it from time to time. Different times of the life milestones. So births, deaths, marriages, divorce, birthdays. Come back and look at it from time to time. Make sure it's still accurate. And the person that you've chosen is still the person that you want. Well, for those of you who recognize that this document, it might be too far long that we can't do this for mom, there is still things that you can do. So this scenario, mom has mild cognitive impairment. It's gotten developmentally worse over the years, but today mom is having a great day. She's reminiscing, she's telling stories. It's such a joy, and I really wish she had more of these days. This is your opportunity to capture the day. Take that opportunity to film those moments with mom. If she's telling a story, whip out your phone and just record her. You'll be so grateful to have those memories recorded and that you can review, that you can share with loved ones. Also, if you're able to get into that space where you can have this conversation and say, hey, mom, if something happened and you got really sick, would you want me to take you to the hospital? There's things happening right now. It's an opportunity to kind of facilitate that on a good day, at least so you can get the best information that you can from them during that time. So if you have questions about the advanced directives, by all means, you can put them into the Q&A, and we'll hit that at the end. We're going to move on to POLST. POLST is the bright green form. It's the provider's orders for life-sustaining treatment. Many of you in the poll in the beginning are aware of that, which is great. It used to be called the physician's order for life-sustaining treatment. It's been changed to provider's order for life-sustaining treatment, and that is so that our APRNs, our advanced practice nurses, are able to sign as well as physicians. So it has some pretty standard information, your name, who would be your emergency contact. The first question on it is if you were found with no pulse and not breathing, and I'm going to let you folks kind of mull on this a little bit. The person has no pulse and is not breathing and is not responsive. They're dead. We don't do CPR on people who are alive. So the first question on the pulse is, if you are found with no pulse and not breathing, would you want CPR? Now, to give you a good description of what CPR is, CPR, if you see it on TV, it looks like, hey, that doesn't look so bad. But in real life, it can be quite a violent thing. CPR goes, you have to be effective in restarting a heart or potentially restarting a heart. It's not always going to restart. You need to go in, press chest compressions 3 inches into the chest cavity. So if you think of your loved one who you're contemplating whether we're going to do CPR, in order to be effective, we have to press into the chest this far down, which means it's highly likely that there will be some bones breaking in order to be effective. It's also important to point out that CPR is not really meant for the elderly and the frail. It is meant for a sudden cardiac event. So there are statistics that say at the age of 70, the ability to recover is right around 11%. 70 and over, 11%. And as you get older, that percentage decreases. So by 80%, 80 years old, it's like a 3% chance of recovering. So again, if you are found with no pulse and not breathing, would you want EMTs to initiate CPR, or would you rather them allow a natural death? And this is the first question on there. Again, these are questions that you'll be talking with the provider about. You have the opportunity to talk to your nurse or your doctor about these and ask lots of questions, but we want to give you kind of a baseline of the form. The second part is, what level of care would you want? Let's say you're still breathing and you have to go to the hospital. What would you want? What kind of care would you want? Would you want all the bells and whistles, a full treatment? Try every medical intervention. Limited interventions, that means you'd like some intervention, but you don't want to go to the ICU. And then comfort measures is intended for people who just want to be kept comfortable. Oftentimes those are hospice patients, but that's not always the case. But they're not wanting to be in a hospital, but they want to be kept comfortable, so they want their needs addressed. But they don't want to have medical interventions. So you get to choose which level of care you would want. Now, if you ask for CPR, you automatically get full treatment. There is no workaround for that. So you can't say, give me CPR and then give me comfort measures. It doesn't work like that. In order for CPR, if it is effective, to be helpful, you'd have to go to the ICU where they can actually do all the medical interventions that are needed to bring you back if they're able to be successful with the CPR. If you say allow natural death or do not attempt resuscitation, you get to choose any of these measures. You get to choose whichever level of care that you would like. Now, some people say, well, why would I say allow natural death, but I'd still want full treatment? Well, keep in mind, we're talking about kind of two different things, right? So if I'm alive and I want full treatment, that's fine. But if I've already died, I don't want full treatment. That's what is being said with this diagram. Then we also have something on artificial nutrition and hydration. Keep in mind, again, they will try to feed by mouth as much as feasible. But this is the opportunity to say, would we take this route? And then you have to get it signed. So unless it's been signed by either an advanced practice registered nurse, an APRN, or a nurse practitioner, a physician, it's not legal. Even if you have a form and you filled it out yourself, unless there's a license and a signature, the EMTs will not honor this. So it is important to recognize that. Now, it does have the opportunity to name an agent, a legally authorized representative. Now, keep in mind, this is not the same thing as your agent, but it's your legally authorized representative. This person does not have the same authority as if you had named them in an advance directive. So this is something to recognize. So although you may already have a POLST, if you don't have an advance directive to back up who's in charge, there could still be some issues of who's in charge. So this is important to recognize that oftentimes folks with dementia would have a designated surrogate. Somebody's already stepped into that role of being the authority figure. But if we're still in the early times, you could have, actually, that would be the non-patient designated surrogate, excuse me. So that's when the group of loved ones come together and they get to choose who's in control. That's your non-patient designated surrogate. Now, if we're in a facility and mom says, hey, I want my daughter to be my spokesperson, that's a designated surrogate. That's when the person is designating. Again, these aren't the same authorities as the person named in a healthcare advanced directive, an advanced healthcare directive. The surrogate information, if it's a non-designated surrogate, that's when you would sign the back. Some practical considerations about this is it's on lime green paper for a reason. It's on that obnoxious green paper so that they can be found easily. It's meant so that when EMTs come in, they take one look around the room and they see it. And this is how they're going to guide and govern the care that they provide the individual in need. So keeping it on the refrigerator, that's where most people like to have it live, taped to a bedroom door, next to the bedside table, medicine cabinet, someplace easily found. Now, what we do recommend is that if you have the POLST and an advance directive, put those in a plastic sleeve and have them together so that they're readily available if the need arises that they need to be transported, that the individual needs to be transported. So we asked this question in the poll, who would benefit from having a POLST? Now, I believe in the poll we asked at what age. We want to be very specific and let you know that it is not an age type of form. Just because you're 65 doesn't mean you should have it. This form is meant for people with chronic progressive illness. It's meant for people with a serious health condition. Maybe they're medically frail. This is for a person who would want a do not resuscitate order. They want to allow a natural death. This is also a form that might be considered for people who don't want to be taken to a hospital during a pandemic. But the question that we say to use is, would you be surprised if the patient died within the next year? And if your answer is, well, no, I wouldn't be surprised, then that's a good candidate for the POLST. Some considerations surrounding the POLST, because COVID-19 has changed the way hospitals are being done, recognize that visitors might not be allowed in. So if you are doing a POLST for a loved one with dementia, you might want to take that into consideration. Don't think of that as deterring, but at least so that you're mindful that, hey, if we go to the hospital and they have to stay at the hospital, we're going to have to figure out something on how to keep mom or dad comfortable and feeling safe, because the hospital can be quite a scary place. Even without dementia, it can be quite scary. So we really want to give you that opportunity to have these conversations before having to make a decision. So the differences between the advance directive and the POLST. Advance directive, everyone over the age of 18 should have one. POLST is meant for that certain demographic, right? That certain population. The POLST, think of it as a right here, right now, what are we going to do? Whereas the advance directive, we're looking into the future. If something should happen and I'm not able to speak, what should we do? That's the advance directive. CPR is not addressed in the advance directive. And even if it is, the EMTs cannot honor that. So although you may have said in your advance directive, let's not do CPR, EMTs, by law, they're required to do it. So the only way they can honor that is through a POLST. If you have questions about the differences between the two, feel free to put your questions into the Q&A and we will address them at the end. Because everyone needs an advance directive, and actually everyone over the age of 18 needs an advance directive, but not everyone needs a POLST. So where does a POLST fit in? Again, we start these conversations early in life, encourage young adults to have their advance directive completed. And as life moves on, things change, weddings, children, all of these things happen throughout life. We want to come back and review it. The advance directive, it should be a living document. Whereas the POLST, it's meant for serious illness. So your advance directive can change throughout life. Your POLST can also change throughout whatever health crisis you may be facing. These conversations are really an opportunity to increase awareness of what you would want, what you wouldn't want. It's also an opportunity to introduce palliative care, and we'll talk about that in a little bit, and also hospice. Really what we're doing is changing the question from what's the matter with me, to what matters to me. So palliative care, it's a specialized medical care, and it's for people living with serious illness. It is not the same thing as hospice. Hospice is meant for end-of-life care. Palliative care is meant to support folks through serious illnesses, through health crisis. They look a lot alike, but there's different goals here. So with palliative care, you get a care team, which is usually a doctor, a nurse, a specialist, it's an extra layer of support. I have a classmate who she actually got palliative care out in Hilo, and she loved it. So she has stage 4 cancer. She's living with stage 4 cancer. And when she started using her palliative care benefits, she was so surprised and impressed with how much integration the social workers did to help support her after she got her first treatment. She was having bad reactions, and with those bad reactions, she called the nurse. The nurse immediately called the pharmacy. They were able to balance her medication so that she wasn't feeling that way. She had gotten behind on her bills because she had to take time off. The social worker was able to find money to help her pay to maintain her household, and she had kids who are in high school. The palliative care specialists, they were able to kind of check in on her right after treatments and then a few days later to make sure she was doing okay. It's just an extra layer of care provided for folks with serious illness. I can't stress enough that if you're going through a serious illness and you qualify for palliative care, you ask for it. It can be found in different settings, but it includes, but it's not limited to pain management. And in Hawaii, it's important to recognize services for palliative care. They're either inpatient, meaning in a hospital setting, or they're provided by hospice providers. But remember, it's not hospice care, but hospice has already been set up with a team approach to supporting individuals and their loved ones. Palliative care, you can continue curative treatment. So you can continue to get the radiation, you can continue to get the dialysis, you can continue to get whatever your needs are. And this is to support you throughout your health crisis. Hospice is different. And hospice, it should be introduced as early as possible whenever there's a diagnosis of a terminal illness. With Mom, when she couldn't take the tube feeding, I immediately thought, okay, let's talk about hospice. Hospice, the word itself, sometimes it brings different things to people's minds. So when I approached Mom about considering hospice, I said, Mom, and Mom was a school teacher. She had been a school teacher for 50 years. Mom, you have been invited to the Cool Kids Club. And her eyes lit up. She said, what's that? I said, well, in the Cool Kids Club, you get your own doctor, you get your own nurse, you get your own social worker, you get your own aide, and you get your own spiritual advisor. And her eyes got huge and she said, I want that. And I said, well, you can be in the Cool Kids Club. And she's like, yes, I want the Cool Kids Club. I think recognizing that approach and how much support individuals get, knowing that you can get that early on in diagnosis, that can really help throughout the last stages of life. People are actually known to live longer with hospice. You might even have heard of people getting kicked out of hospice or graduating from hospice because they got such great care that they were actually able to get better. So we encourage you, if there's a terminal diagnosis, if there is a health diagnosis, which they say will be lifelong, ask, are they able to get hospice? Hospice is a wonderful benefit and it's paid for. Now, when I say it's paid for, I mean the services of people coming in to provide the services, whatever items you may need, incontinence items, any equipment, that's all covered by hospice. So again, if you paid into hospice, if you paid into Medicare, use your benefit. You'll have care where you want, which is generally in the home, and that team coming to the home to provide the care. Kokua, we have all our hospice providers and palliative care resources. We have them available for you to go online and look at. We want to make sure that you have as much information as possible. If you're not sure whether your loved one or yourself qualifies for palliative care, ask. It doesn't hurt to ask. And what that also does is it cues your provider to recognize that, hey, you are not afraid to have a hard conversation, and you're willing to try and get as much care as possible. And that really helps them to have a conversation with you about what matters most to you. And we really want to ensure that what matters most to you, your loved ones know, your providers know, and that you're able to support one another. We invite you to come and join us at Kokua Mau. We have an e-newsletter that goes out. And if you're interested in being on our mailing list, we're happy to have you sign up on our website. We have 10 different translations of materials online that you can use. We also, if you appreciated this presentation, or you want to do this presentation with, say, your church or your book club, your seniors club, let us know, reach out. We're happy to continue these conversations out in the community via Zoom right now, because of course, we're doing everything different because of COVID. But we're happy to come and talk to your group. We're happy to set up a Zoom so that we can do this with you in your circles. Our resources. These are just some of the resources online that you can look at. We encourage you, once again, when you're thinking about all of this, do it for yourself first before trying to do this for someone else. And I assure you, starting a conversation with saying, Mom, now that you're 75, we need to have a conversation, that never goes well. However, when you say, hey, Mom, I did this for me. Hope at Kokua Mau challenged me to do this. So I did this for me, and I wanted to share this with you and hopefully learn from you as to what you would want. That's facilitating a conversation that could be beneficial. So again, I appreciate you taking time to join us here. And this is my contact information. Again, I'm Hope. My phone number there. Feel free to give me a call, email. Happy to help you with that, whatever questions you have. We invite you to come and look at our website, kokuamau.org. And again, we thank you. So I'm going to stop sharing, and I see there are some questions in there.
Yeah, hold on. I'm going to switch to my slideshow. Thank you so much, Hope. So in my part of this, I'm going to build on Hope was talking about that part of the form about food and whether you want tube feeding or not. And I specifically want to talk about dysphagia and dementia. So the dysphagia is having issues with swallowing. So you start to notice, I'm going to go into what kind of signs you'll see, but when someone is living with dementia, we think of it most often as memory problems or repeating themselves a lot, things like that. But that's one part of the brain, which are short-term memories. But the diseases that cause dementia, and it's not a part of normal aging, affect the whole brain, including those core functions that we don't think about. They just happen naturally: breathing, swallowing, things like that. We don't have to think like, wait, do I open my windpipe or my throat? We just do it. We've all had the experience of accidentally aspirating something when, it could be because you're laughing so hard or just something happens. But it's actually a pretty complicated process that we take for granted. So as the person's brain is changing and slowly dying from the diseases like Alzheimer's disease, Parkinson's disease, strokes, issues with swallowing become so common. 9 out of 10 people who are living with dementia will experience problems with swallowing at some point. So sometimes it can happen acutely, which is not a gradual change, but something sudden, like from a stroke, or it can be progressive, as for those living with other causes like Parkinson's or Alzheimer's disease. So how do you know if someone is experiencing dysphagia? You will see a lot of extra saliva. They might take a long time chewing. They're putting food in their mouth, and it looks like maybe they're eating normally, and then you discover it's not being swallowed, or it might even just be coming right out. They may start chewing food and spitting it out instead of swallowing it. It might come out the nose. Very often when they are swallowing, there's a lot of coughing. There's just, and you hear a lot of gurgling. There may actually be pain, or you might start to notice that they're eating, but they're not holding on to the weight. And then the last one, which is so common, it's called aspiration pneumonia. So when it doesn't go down the correct tube, it goes into your lungs, and then that can lead to pneumonia. So there might be repeated aspiration pneumonias, and that's a very serious a serious thing that can happen. So it can happen in thinking about this. So someone's having trouble swallowing now, and Hope talked about her mom and the feeding tube, the temporary one up the nose. I had a very similar experience with my father, who had vascular dementia, and again he had strokes, so he couldn't, at a certain point, he couldn't swallow properly, couldn't take his medications, just like Hope's story. So they opted to try that tube, and it was the same experience. It was so painful and uncomfortable that he said, no, no, we can't do that. So it's finding that balance of, what is the quality of life with this choice that we have to make, versus the benefit there. So it can be really challenging. So one of the first things, if you're noticing those signs of someone, coughing, pocketing, you'll want to get take notes. I always encourage, for all things about dementia, when you're noticing things, take notes. There's almost like a detective. Write down what you're noticing. So because when you go to the physician, sometimes it's hard to remember exactly. So see if you can get a speech pathologist assessment. And so they would come in and they would watch the person. I would probably be by Zoom these days, but watch and see how they're eating, and they will give really specific adjustments that you can make. So one of the things might be having the food be chopped, or having it be fine chopped, which is grain of rice size, or even pureed. Sometimes if the issue is around swallowing liquids, you might have to have the liquids thickened. So there's water is the base liquid. So that, let's say anything that's as thick as water, I'm choking on. The next level would be nectar consistency. And that's the most common one I like to tell people is guava juice. It's like as thick as guava juice. And then the next thickness thicker than that is honey. So we want to find what will work for me. So I might not, because it's not so loose and as water, I can do a better job of getting it down the right tube, and not choke and not aspirate. Those are the things we want to, and enjoy my food. And that's the other thing. Hope talked about food is love. That does change as we're going through our journey of dementia, and how can we make changes so that I can still enjoy it? I mean, it is life-sustaining nutrients too, but so generally we try and chop as we don't want to go straight to puree unless it's necessary. If I do good with chopped, great, I do well with that for a while, and then maybe a few months down the road I might need to go to fine chopped, but we can keep making changes. Positioning, creating a familiar and forgiving dining environment. By familiar and forgiving, when people are living with dysphagia, and things will be a little messier in general. We want to make sure that things are set up so it's not a big deal, so that I can still be successful in enjoying the food, whether it's I'm eating the cut food with my hands, or if I'm sipping, and if I still have spills, to have that set up so that nobody freaks out about it. Even if food has to be changed in consistency, it can still be visually appealing. Even puree, if you think about delicious pureed soups or things that you've enjoyed, delicious desserts that are soft like that, it doesn't have to just look like a bowl of mush. It can be visually appealing. And watching people to see if they've actually swallowed. The first few times you actually watch it, if you see the signs of dysphagia, when you're watching the person who's pocketing, you might notice that there's that Adam's apple, even in women, doesn't doesn't have any movement. And that's the sign that, oh, you know, I shouldn't put any more in her mouth, or maybe I need to make some changes here. Alternating between food and liquid can help clear any residue. And then the last two, if you're seeing that in spite of all these changes that you've made for me, that maybe they used to work, that I am not able to swallow now, pause, take a little time out, step back. Again, take notes, let the physician know, and reassess the safety of eating. And that's a hard thing to say, the safety of eating, because eating seems so safe. But the risk of forcing food and the risk of aspiration, the pain and discomfort that can come from that is quite profound. I know the question on the POLST about tube feeding can be a tough one, and I Hope was saying that we'll have that link about how it's not recommended for people who are living with dementia. It's I have a personal story about my father-in-law who was living with Parkinson's, and they had a very very actively involved in planning his own advanced care directives and even his POLST as well. And he definitely wanted everything. He wanted all the treatments, and he was able to participate in that. But the hard thing about tube feeding for people who are living with dementia, this is the what's going through the abdomen tube feeding, is even though there's nutrients going in, the body is shutting down, and it doesn't necessarily lead to weight gain and recovery. Even people who can eat as you reach towards the end of your life living with dementia, you can eat, and let's say you don't have dysphagia, you'll start to notice that they're losing weight even though they're eating. That primitive, that part of your brain, like I was saying, that controls automatic things like swallowing and nutrient absorption, that's not working so well anymore. And it is also possible to aspirate with tube feeding. The risk of aspiration is not erased by having a tube feeding, because I can aspirate, someone living with dementia, if I have dysphagia, I have excessive drooling probably, I'll aspirate my own saliva. And with having contractures towards the end of life, that your whole abdomen is more contracting, you can aspirate from the food from tube feeding going up the other way as well. So the risk is not eliminated of aspiration through tube feeding. So that's a hard thing, and it is not uncommon for people with dementia to pull out their feeding tube if they have one, because it's just the same way of any other thing, the IVs, and often with those kinds of things stuck in your body, people who are living with dementia may end up having to have restraints in a hospital setting for those kinds of interventions. So being mindful of what the experience of having that in would be like. But as Hope said, it's an individual choice, it's family choice, but just to keep aware of what would that look like, and how long that can last. Oops. So I want to make sure that we have enough time for questions and all. I wanted to, and I'll be doing a webinar on Thursday, the 12th, to go more into depth about dining and making adjustments to dining and enjoying food. I wanted to give a message about dysphagia and dementia. It's about our relationship with the person, and even though that relationship is often around food, it's not just about getting it in and getting it done. We want to offer, but not to force, even if it's just a little taste, and if that's all I can enjoy, and without choking, that is still something. So we can still connect, even if I'm not able to swallow anymore. We can still find love together and around food. It can even be smells of food, but it's different at this stage of life. So I want to go to here. So that was just like a dysphagia in a nutshell, but I'm so happy we have this video. This is a screenshot through the Jabson, geriatrics.jabson.hawaii.edu, all about dysphagia, and it's not all me. There are geriatricians on there talking about the really, really in depth of what dysphagia is, family stories, this is me demonstrating a hand under hand technique for helping someone eat. And I even make an appearance demonstrating how to do chopped and pureed foods and presenting them in a way that is more, that can be very appetizing still.